If you've ever had a horse, or well, even just been around them much, you know that lameness and joint issues are. They're just incredibly common and
Oh,
frustrating.
absolutely. A huge reason for downtime.
Exactly. Time off, or sometimes even early retirement. But imagine if you could actually peek inside that joint,
Oh,
to really see what's happening, not just guess from the outside.
hmm. Well, that's exactly what we're diving into today. The fascinating world of equine synovial fluid. You probably know it as joint fluid.
That's the one?
This deep dive is all about uncovering its vital role in a horse's joint health. You know, how it functions perfectly when things are normal, how it changes with disease, and crucially, how we figure out those changes to help horses get better.
That's right. And synovial fluid, it's really far more than just like a simple lubricant. It's genuinely the lifeblood of the joints.
Lifeblood, okay.
Yeah, it has this dual role, and it's indispensable. First, it's the main source of nutrition for the articular cartilage, which, interestingly, doesn't have its own blood supply.
Right, I remember that. It relies on the fluid. Totally relies on this fluid for, well, for everything it needs to survive. And second, yes, it is a high-performance lubricant. It minimizes friction, minimizes wear between those joint surfaces, allowing for that incredible movement horses have.
Wow.
So analyzing this fluid isn't just, a good idea for diagnostics. It's absolutely an indispensable component for tackling common things like osteoarthritis, and especially for critical orthopedic emergencies, things like septic arthritis or tendinosynovitis, where every single moment really counts.
Okay, let's unpack this a bit. Given how absolutely crucial this fluid is, why is catching problems early, based on analyzing it, why is that so paramount?
Well, because without recognizing these issues quickly and treating them aggressively, these conditions can lead to really severe, often irreversible complications.
Irreversible.
Yeah.
Okay.
We're talking profound lameness, permanent cartilage damage, and ultimately, the loss of the horse's athletic ability. So early detection, driven by a comprehensive synovial fluid analysis, lets us intervene before those irreversible structural changes really take hold.
Right, before it's too late.
Exactly. This can literally extend an equine athlete's career, preserve that joint integrity, and significantly improve their long-term soundness and well-being. It's all about catching problems when they're still, well, potentially reversible.
So let's start with the ideal picture then. What does healthy synovial fluid look like? How does this, you called it a finely tuned biological machine. How does it normally operate? Where does it even come from? What's it made of?
Okay, so think of a healthy joint as this incredibly efficient, sort of closed system. The fluid inside, in its normal state, actually starts as an ultrafiltrate of plasma.
Ultrafiltrate, so like filtered blood plasma.
Exactly, very carefully filtered.
Mm-hmm.
But then the joint's own specialized cells, they're in the synovial membrane. They actively fine-tune it. They secrete really vital components like hyaluronic acid HA, which is key for that lubrication, and other important things, macromolecules. What's critical here is that it maintains a very low protein environment. Imagine like a bouncer at a club, restricting the bigger plasma proteins from just wandering in, keeping the environment really pristine. Smaller molecules, though, like glucose, electrolytes, they pass through easily. They're present at concentrations pretty similar to blood plasma.
So its main jobs are feeding that cartilage and lubrication.
Those are the big ones, yeah. Nutrient delivery and smooth movement.
That really paints a picture of a complex, very delicate system. So when a vet actually draws a healthy sample, what are the immediate physical things they're looking for? What does normal look like, just, to the naked eye?
Great question. A healthy sample should be light yellow or pale yellow, and maybe most importantly, perfectly clear.
Clear, okay.
Yeah, you shouldn't see any cloudiness, no particulate matter floating around. And crucially, a healthy sample does not clot.
Ah, that's a key point.
Huge red flag if it clots.
Yeah.
That immediately tells you something abnormal is going on, usually inflammation or maybe contamination during the collection. Another interesting property is something called thixotropy.
Thixotropy.
Yeah, think of like a non-drip paint. It's thick in the can, but flows easily when you stir it.
Right.
Synovial fluid is kind of similar. It might seem a bit gelatinous if it sits undisturbed, but with just a little movement, a little agitation, it quickly becomes fluid again.
Huh, interesting. And that brings us to viscosity, right? I think listeners will find this fascinating. How do you actually check that? What's the string test people talk about?
Viscosity, yeah, basically how thick and resistant to flow it is. It's absolutely critical. We commonly assess it with what's called the string test.
Okay.
If you take a drop, let it fall from a needle, or you can use an applicator stick to sort of stretch it. Normal synovial fluid should form a continuous strand of at least, say, 2.5 centimeters, about an inch before it breaks.
A whole inch. Wow.
Yeah, this high viscosity is a direct indicator that you've got enough hyaluronic acid and that it's properly polymerized, structured correctly. It's that high-quality HA that lets the joint work like a well-oiled machine. If that viscosity drops, it immediately signals a problem.
So beyond what you can see just by looking, what are the normal things you find when you go microscopic? The cells, the biochemistry. What tells you it's a truly healthy joint?
Right. So when we zoom in, a healthy joint's fluid is like, well, think of a pristine, low-traffic road. You see very few cars or cells.
Yeah.
Specifically, the total nucleated cell count, TNCC we call it, should be incredibly low. Typically below 500 cells per microliter for most limb joints.
500, that's really low.
It is. It tells us a healthy joint is a calm, very low inflammation environment. Red blood cells, almost none. Should be pretty much absent. Now, looking at the types of cells, the vast majority, maybe 50 to 90%, should be mononuclear cells. These are primarily macrophages and synovial lining cells, basically the joint's resident cleanup crew.
Right.
And here's a crucial point. Neutrophils, those are the white blood cells we associate with acute inflammation, infection.
Yeah, the fight.
Exactly. They should make up less than 10% of the total cells. And the ones that are there should look normal, non-degenerate. Biochemically, the total protein concentration is also quite low, typically less than 2.5 grams per deciliter.
Also low.
Very low. Glucose levels are generally similar to what you'd find in plasma. And the mucin clot quality, that's another test looking at the hyaluronic acid integrity, should consistently be good. It forms a single, compact clot in a clear solution. It's this intricate interplay of all these components that makes the joint that finely tuned biological machine we talked about. Disrupt any single element, and you can have significant cascading effects down the line.
Okay, we've painted this picture of, well, joint perfection. But what happens when that finely tuned machine hits a snag? How do we actually, as investigators, get those clues out of the fluid? What's the diagnostic process itself look like?
Yeah, you're hitting on a really critical point there. The integrity, the usefulness of the whole analysis, it truly starts with meticulous sample collection and handling. Aseptic technique is just paramount.
Meaning super clean. Super clean. You absolutely have to avoid introducing bacteria from the skin into what should be a sterile environment. That's called iatrogenic infection, procedure-induced. We don't want that.
Right.
It's also crucial to collect samples in both an EDTA tube, that purple top tube, it preserves cells for counts and cytology, and a plain or serum tube, a red top, basically. That one's needed for bacterial culture and the mucin clot test, because EDTA actually messes with those tests.
Okay, so 2 tubes.
2 tubes. And then preparing smears directly from the fluid, right when you collect it, is also critical. Those cells in the fluid can degenerate really fast, making them hard to identify accurately later on.
So do it right away.
Right away. The tubes themselves should be refrigerated, put them on ice, but use like a paper towel as a barrier so they don't actually freeze, which would damage the cells.
Right.
The smears, though, keep those at room temperature.
And even small details matter. If you only get a tiny bit of fluid, say less than 0.2 milliliters, collecting it in a special microtainer tube is important. Otherwise, the ratio of anticoagulant to sample can be off and artificially inflate the protein reading.
Wow. Lots to keep track of.
It is. And failing to follow these steps can create artifacts, things that look like disease but aren't. Like blood contamination is pretty common during collection. It can falsely increase your cell counts, your protein, your neutrophil percentage, and decrease viscosity. It could easily make you think there's inflammation or even infection when there isn't. It leads to misdiagnosis.
Okay, so assuming you get a good, clean sample, even before sending it off, what can you learn just by looking at the fluid right there in the syringe, that initial macroscopic look?
That macroscopic evaluation gives you immediate, really valuable clues. First, you look at the volume. Is there more fluid than expected? That's called effusion or hydroarthrosis. It strongly suggests inflammation, maybe acute synovitis from trauma. Although, interestingly, chronic OA can also cause an increase, but often it's a smaller increase.
Okay, volume first, then?
Then, color and clarity. We said normal is pale yellow and clear. Turbidity, cloudiness, that's a strong indicator of increased cells, meaning inflammation. If it's cloudy or turbid, especially if it's also maybe orangish or uniformly red, watery, and has little clumps in it, we call that floccular. That's highly suggestive of infection.
Okay, cloudiness is bad, potentially infection. What about blood? You mentioned contamination.
Right. Differentiating true bleeding inside the joint from just poking a vessel on the way in is key. Streaks of blood usually mean contamination. But if the blood is uniformly mixed in or the fluid has that dark yellow xanthochromic look of old blood, that suggests true hemorrhage happened inside the joint.
How can you be sure?
Well, microscopically, if it's true hemorrhage, you might see macrophages actually eating red blood cells. That's erythrophagia, or fine hemosiderin, which is like rust from old blood. You wouldn't see those with simple contamination. Sometimes platelet clumps also suggest recent vessel damage from the needle stick.
Got it. And viscosity.
Yep, back to viscosity. If it's decreased, if that string test is poor or the mucin clot test comes back poor, that's a general indicator of inflammation and that the hyaluronic acid is getting degraded. So these initial checks, volume, color, clarity, hemorrhage signs, viscosity, they're immediate, they're cost-effective, and they really act as a crucial gateway guiding us on what further, maybe more complex tests are needed.
So the naked eye gives us some vital first impressions, but to truly understand the whole story, we need to zoom in, right? Put it under the microscope. What does that tell us?
Absolutely. The microscopic exam, the cytology, the cell counts, that provides the really detailed critical information. As we said, normal TNCC is low, under 500 cells per microliter usually. When that count increases significantly, it's a strong sign of disease.
How high can it go?
Well, in non-inflammatory conditions, it's usually below 5,000. If there's been hemorrhage, it might go up to, say, 15,000. But in true infection, sepsis, it can be extremely high, often over 30,000, sometimes way over 50,000 cells per microliter.
Wow, that's a huge jump.
It is. But, and this is important in the very early stages of sepsis, maybe the first 24 hours, the TNCC can be deceptively low, sometimes only around 10,000. That can make it really tough to differentiate from just sterile inflammation initially. Now, looking at the red cells again under the microscope, if we see those macrophages actually eating red blood cells, erythrophagia, that tells us there's been recent bleeding inside the joint. If we see the breakdown products like hemosiderin, that means the bleeding happened a while ago, maybe days or even weeks prior.
Okay.
But the differential cell, count the percentage of each type of white blood cell that's perhaps the most crucial piece of the puzzle microscopically. Remember, normal fluid has very few neutrophils, less than 10%.
Right.
In inflammatory conditions, that neutrophil percentage jumps up, usually over 10%.
Right.
And in septic arthritis, it often rockets to 90% or even more of the total cells.
90% neutrophils.
Yeah.
That's almost all of them.
Pretty much. But here's another critical point about septic synovitis. Sometimes the neutrophils can look normal, non-degenerate. And surprisingly often, you don't see bacteria on the direct smear.
Really? Even with infection?
Yes, which is why relying solely on seeing bacteria is dangerous. You need the whole picture, the cell count, the neutrophil percentage, the protein, etc. Other microscopic clues, you might see activated macrophages. They look kind of foamy in non-inflammatory disease. And rarely, but significantly, you might find osteoclasts. These are huge cells, way bigger than neutrophils, and finding them means severe cartilage damage, right down to the bone. You might even see actual cartilage fragments floating around.
And beyond just the cells, are there specific chemical markers in the fluid itself that give us more clues?
Yes, absolutely. Biochemical analysis adds another crucial layer. Total protein, normally low, gets significantly elevated in both inflammation and trauma. In septic fluid, it's typically quite high, often over 4.0 ovulize per deciliter.
Okay, high protein. What else?
Glucose levels. Normally, they're similar to blood plasma levels. But in septic joints, the glucose level drops significantly.
Why is that?
Because the bacteria and all those inflammatory cells are rapidly consuming the glucose for energy. So you compare the glucose in the blood serum to the glucose in the synovial fluid, and the difference is more than about 2.2 millimoles per liter. That's highly suggestive of sepsis.
Got it. Low glucose in the joint fluid.
Right. Lactate levels also go up in acute infection. Levels over 4.9 millimoles per liter strongly point towards septic arthritis.
Okay, lactate goes up.
And then there's serum amyloid A, SAA. This
Yeah.
is a really powerful marker. It's normally very, very low in synovial fluid, less than 5 micrograms per milliliter. But in septic arthritis, it increases significantly, often over 100 micrograms per milliliter.
Wow.
And critically, it does not typically increase much in sterile synovitis. So SA is incredibly useful for helping differentiate true infection from just inflammation, especially once the clinical signs have been around for maybe 6 hours or more.
So that sounds really useful.
It is. And we're also seeing exciting emerging biomarkers, things like myeloperoxidase and lysozyme, which are enzymes released by neutrophils, are showing great promise for developing rapid, maybe even stall-side tests for sepsis. And then there are cartilage degradation markers, things like CAPMP, CS846, GEGS, CTX2. These are being explored as potential early indicators for osteoarthritis, maybe even increasing before the horse looks lame, which could give us a chance to intervene much earlier.
What about directly identifying the actual cause, like finding the bacteria themselves, or maybe even crystals, if that's the issue?
Good question. For bacterial infections, doing a bacterial culture of the synovial fluid is technically considered the gold standard. But, and this is a huge but, traditional culture methods have a surprisingly high false negative rate.
Meaning they missed the infection.
Yeah, they only come back positive maybe 25 to 70% of the time, even when there is an infection. Using specialized blood culture bottles improves that rate somewhat, but is still not perfect. A gram stain, which is a quick stain to look for bacteria under the microscope, also has pretty low sensitivity.
So the takeaway is,
The crucial takeaway is, not seeing bacteria on a smear or getting a negative culture does not rule out sepsis. It's why all those other fluid parameters, the cell count, neutrophils, protein, SAA, are so incredibly vital. Molecular diagnostics, like PCR that looks for bacterial DNA, are much more sensitive, but they have their own challenge with potential false positives from, say, environmental contamination.
okay. And crystals, you mentioned those earlier.
Right, crystal analysis is much less common in horses than in people, but worth mentioning. Gout involves monosodium urate crystals, which are needle-shaped. It's sometimes linked to purine metabolism issues, maybe stress. Pseudogout involves calcium pyrophosphate dihydrate, or CPPD crystals, which look more rhomboid or rectangular.
Well, how do you spot them?
Both require using a special type of microscope with compensated polarized light to see the characteristic shapes and how they interact with the light. Both conditions cause inflammation, and finding the specific crystals is how you diagnose them.
Okay, so we've talked a lot about the clues themselves, what they look like, how we find them, but now let's connect the dots. Let's play detective. When these different parameters start to shift, what story is that fluid actually telling us about what's wrong? How do these changes translate into a diagnosis?
Exactly. This is where it all comes together. Let's start with simple synovitis. That's sterile inflammation, meaning no infection. It's just inflammation of the synovial membrane,
Yeah.
often triggered by things like trauma, maybe overuse, or even a foreign body getting in there.
Okay.
In these cases, the joint's resident cleanup cells, the macrophages, can sort of switch gears and become pro-inflammatory. The key fluid changes you'll typically see are a decrease in the hyaluronic acid concentration and therefore the viscosity, so it's less lubricating. And you might see elevated levels of things like prostaglandin E2, which is involved in pain and inflammation.
And the SAA.
Good point. What's really important and helpful for diagnosis is that serum amyloid A levels typically remain normal or only slightly elevated in sterile synovitis. That's a key way we differentiate it from infection.
That is helpful.
It is. But it's also vital to understand that even routine things like repeatedly tapping a joint for samples or giving an intra-articular injection can temporarily cause an inflammatory reaction. You'll see increased white blood cell counts that can mimic infection for a short time, usually resolving within maybe 1 to 3 days. This post-procedure inflammation can be a real diagnostic curveball sometimes.
Okay, so that's sterile inflammation. What about the really scary one, septic arthritis?
Right. Septic arthritis is a true orthopedic emergency. It causes rapid, often irreversible joint damage, so time is absolutely critical. When bacteria manage to colonize the joint's base, it triggers this intense inflammatory cascade. You get a massive influx of neutrophils rushing to the scene.
The fighters arrive.
They do. But, as we mentioned, they're kind of a double-edged sword. While they're essential for killing the bacteria, they also release powerful enzymes and destructive free radicals that unfortunately chew up the joint's own components, like proteoglycans and that vital hyaluronic acid.
So they damage the joint while trying to save it?
In a way, yes. This dramatically reduces the synovial fluid viscosity, compromising the joint's natural protection and lubrication. At the same time, inflammatory messengers called cytokines like IL-1, IL-6, TNF-alpha, and matrix metalloproteinases, MMPs, ramp up cartilage degradation. You also get fibrin accumulation, like sticky clots forming and sometimes pannus formation, this abnormal destructive tissue that grows over the cartilage. All of this complicates treatment and contributes to long-term damage.
And the fluid reflects this chaos.
Absolutely. The hallmark synovial fluid changes in sepsis typically include that orange or reddish, cloudy, turbid, watery, non-viscous appearance. The total protein skyrockets, usually over 4.0 GDL. The total nucleated cell count goes through the roof, often exceeding 30,000 to 50,000 cells L, with 80–90% or more being neutrophils. And biochemically, you see that decreased pH, increased lactate, and decreased glucose we talked about. It's a very dramatic, very aggressive picture in the fluid.
That intensity really comes through. Now, this raises an important question about the other big one. Osteoarthritis, or OA. Why is OA more than just simple wear and tear? A lot of people think of it that way.
That's a great question, because it's far more complex than just cartilage wearing down like an old tire tread. OA is really a multifactorial progressive degenerative disorder involving the whole joint. The crucial balance between cartilage synthesis, building it up, and degradation, breaking it down, gets completely disrupted.
How does that happen?
Well, the cartilage cells themselves, the chondrocytes and cells from the synovial lining, the synoviocytes, become activated. They start overproducing destructive enzymes like MMPs and agrokinases, which actively break down the cartilage matrix components.
Okay.
Then, as cartilage breaks down, fragments are released into the joint fluid. These fragments act as damage-associated molecular patterns, or DAMPs. Think of them as distress signals.
Blastums.
These DAMPs trigger further inflammation, creating this vicious, self-sustaining inflammatory cycle within the joint, causing even more damage. It feeds itself. And it's not just the cartilage. The underlying bone, the subchondral bone, also undergoes pathological changes. It can become abnormally dense, called sclerosis, and develop osteophytes, which are bone spurs.
So the whole joint structure is involved.
Exactly. And the synovial fluid in OA reflects this complex pathology. You typically see a decrease in the hyaluronic acid concentration and also its molecular weight, which leads directly to that reduced viscosity and impaired lubrication.
Right, less slippery.
Less slippery. You also see increased levels of inflammatory mediators like IL-1 and IL-6, and crucially, those cartilage degradation products we mentioned earlier, TLP, CS846, GAG, CTX2. What's particularly significant is that these degradation markers can sometimes increase even before obvious lameness shows up, offering a potential window for very early diagnosis and intervention.
And the cell count in OA.
The total nucleated cell count in OA is usually within normal limits or only slightly elevated, typically less than 5,000 cells per microliter. So not nearly as high as in sepsis or even some acute sterile inflammation. However, the macrophages you do see might look activated, maybe with foamy cytoplasm, suggesting they're busy trying to clean up cellular debris from the ongoing breakdown process.
Okay. And briefly, the crystal conditions.
Right, the crystal arthropathies, much less common in horses, but they involve the deposition of specific mineral crystals that then trigger an inflammatory response. Gout, as we said, is monosodium urate crystals, sometimes linked to purine metabolism, maybe stress. Pseudogout is calcium pyrophosphate dihydrate, CPPD crystals depositing. Both cause inflammation, and the diagnosis hinges on actually identifying those specific crystals in the fluid using polarized light microscopy.
So pulling this all together, what does this mean for you listening out there as someone invested in equine health? How does all this incredibly detailed analysis actually translate into real-world decisions and hopefully better outcomes for horses?
That's the key question. Synovial fluid analysis, while maybe not pinpointing one single cause every time, is incredibly effective at classifying the joint fluid. It helps us put it into categories: non-inflammatory, inflammatory but sterile, or infectious septic.
Those broad categories are crucial.
They really are. We use that diagnostic matrix, looking at the TNCC, the neutrophil percentage, total protein, viscosity, glucose, SAA, to make that classification. And that classification then directly guides the treatment plan.
Can you give examples?
Sure. For septic arthritis, the fluid analysis confirms the infection is present. Ideally, the culture helps identify the specific bacteria so we can choose the most effective antibiotics. It also tells us we need aggressive physical removal of the infectious material and inflammatory debris, guiding procedures like joint lavage or even arthroscopy. And then repeated fluid analysis helps us monitor how well the treatment is working. For inflammatory arthritis, that sterile synovitis, the analysis rules out infection, which is critical. That tells us we could focus on anti-inflammatory approaches, maybe NSAIDs, possibly corticosteroids, maybe hyaluronic acid injections, or even biologics like PRP or IRE.
Right, totally different approach if there's no bacteria.
Completely different. And for osteoarthritis, identifying those early biomarkers might allow for earlier detection, potentially before irreversible damage occurs. This guides therapies like HA supplementation to try and restore some of that viscoelastic property or other joint support strategies. And monitoring those biomarker levels over time might help track disease progression and how well the chosen treatments are actually working. It allows for a much more personalized, targeted approach based on what the fluid is telling us is happening inside that specific joint.
It sounds like an incredibly powerful diagnostic tool, really a window into the joint. But are there limitations? Or maybe situations where the fluid might not give us a crystal clear answer?
Oh, there certainly are limitations, and it's really important to be aware of them. One of the biggest challenges is that diagnostic ambiguity we touched on.
Hmm.
There can be a significant overlap in the parameters, especially between very early sepsis and acute sterile inflammation, or even just the inflammation that occurs after an injection.
Right, that first 24 hours of sepsis looking like inflammation.
Exactly. The cell count might be relatively low, making it tricky to differentiate right away.
Hmm.
Another huge limitation is with traditional bacterial cultures. We call them the gold standard. Or remember that high false negative rate, they only grow bacteria 25 to 70% of the time, even when sepsis is present. So a negative culture absolutely does not rule out infection. And the gram stain, low sensitivity too.
So you can't rely on culture alone.
Definitely not. You need the whole clinical picture and all the fluid parameters. Then there's the practical issue of iatrogenic blood contamination during collection. It's common, and it can really mess things up, falsely elevating cell counts, protein, neutrophil percentage, while decreasing viscosity. It can mask the true picture or even mimic inflammation or infection.
Gotcha. Any other practical hurdles?
Yeah, a few. The high viscosity of normal or even mildly inflamed fluid can actually make it difficult for automated cell counters to work accurately. Manual counts are often needed. Smears can sometimes dry slowly, which can affect cell preservation for cytology. Getting only a very small sample volume can lead to those erroneous protein readings if you're not careful with the type of collection tube. And of course, especially for critical cases like sepsis, any logistical delays in getting the sample transported to a lab can significantly impact timely diagnosis and getting the right treatment started quickly.
It sounds like a powerful tool, but one that requires careful handling and interpretation, acknowledging those challenges.
Okay.
So where's this field headed? What's on the horizon? What's next for equine joint diagnostics?
Well, those limitations you just mentioned are precisely what's driving a lot of the exciting research right now. We're seeing a huge push into advanced biomarker discovery using omics technologies.
Omics, like genomics.
Sort of, but broader. Things like metabolomics, which studies the small molecules involved in metabolism, and proteomics, which looks at all the proteins. For example, metabolomics has already shown differences between healthy and osteoarthritic equine joints, finding lower levels of certain amino acids, creatine, and choline in OA fluid, hinting at altered metabolic pathways.
Interesting.
Proteomics is busy identifying specific proteins that are upregulated, like one called alpha-2 macroglobulin, which might serve as very early indicators for OA, potentially allowing intervention even sooner. Researchers are also exploring things like extracellular vesicles, tiny communication packets released by cells, and small non-coding RNAs, like one called miR-145P. These might act as early predictors for OA development by influencing inflammation and cartilage breakdown. The big goal of all this omics work is earlier, more accurate, and maybe eventually more accessible detection of joint disease.
And what about faster tests? You mentioned stall-side possibilities.
Yes, that's another really active area. Those enzyme activity assays, particularly for myeloperoxidase, MPO, and lysozyme, LYS, enzymes released by neutrophils, are showing really high sensitivity and specificity for detecting sepsis. This is paving the way for developing rapid, perhaps lateral flow-based tests, like a pregnancy test strip, that could give results right there at the stall in minutes.
Wow, that would be a game changer for sepsis.
Absolutely. And in fact, handheld SAA tests are already available commercially for septic arthritis diagnosis, providing results on the spot. We're also seeing techniques like infrared spectroscopy, FTIR, being investigated for their potential to pick up early inflammatory changes related to OA, maybe even before protein or cell changes are obvious. All these innovations really promise to revolutionize how we diagnose and manage equine joint issues, hopefully leading to much better patient outcomes and helping horses maintain longer, healthier athletic careers. We're moving toward having almost a real-time health dashboard for what's happening inside a horse's joints.
So what does this all mean then? We've taken a really deep dive today into equine synovial fluid. We went from its precise, normal functions, this finely tuned machine, to the subtle and sometimes really dramatic ways it changes when things go wrong with disease. We've seen how it serves as this indispensable diagnostic tool, helping veterinarians tell different conditions apart, guiding specific treatments, and tracking how well those treatments are working. It truly is a remarkable sort of living window into the health of a joint.
It really is. This seemingly simple fluid acts as a continuous real-time report on the state of a horse's joints, providing absolutely vital clues that inform critical decisions every day. And the fact that the analysis is constantly evolving, from just basic visual checks to sophisticated molecular profiling, it just underscores how enduring and actually how expanding its importance is in maintaining equine health and performance.
Understanding this intricate dance of all those components within the synovial fluid, it really reminds us just how interconnected biological systems are, and how much information can be hiding in what might seem like a small detail. It makes you wonder, what seemingly small change in one area of your life might be signaling a much larger story that maybe you haven't fully read yet. We encourage you to keep exploring how these seemingly small biological details can offer profound insights into health and well-being, both for the animals we care for and maybe even for ourselves.